So, I want to start with a hypothetical scenario for you. If a 40-year-old man throws himself onto the floor of a grocery store, just screaming until his face turns a blotchy purple because the deli clerk sliced his turkey slightly too thick.
Right, we definitely don't just ignore that.
Exactly. We don't ignore it. We call security. We probably assume there has been a severe, terrifying break from reality. We look for a psychiatric diagnosis.
Yeah, you assume a total system failure.
But if a 3-year-old does the exact same thing because you gave them the blue cup instead of the red cup, we don't call a psychiatrist. We just call it Tuesday.
It's so true. I mean, it is the defining paradox of childhood. We have this entire demographic of human beings who exist in a state of perpetual psychological chaos.
And we just accept it.
Yeah, we just accept it as the baseline. It's totally normalized.
Right. But it raises this incredibly difficult question for anyone tuning in. How on earth do you diagnose a brain that is literally built to be chaotic?
Which is a massive challenge.
Because if you're a parent listening to this deep dive, or a teacher, or just someone who has ever tried to negotiate with a stubborn toddler or a furious teenager, you know that young people are not just mini adults.
No, not at all.
But for a very long time, the fields of psychology and medicine treated them exactly like that. The assumption was that you could just, scale down adult therapies, put a 7-year-old on a leather couch, ask them about their mother, and just wait for a breakthrough.
Which is honestly a spectacular recipe for failure. It just does not work.
Exactly. And that failure is what we are unpacking today on this deep dive. We are venturing into one of the most complex, high-stakes, and frankly fascinating areas of human psychology.
Yeah, the world of counseling children and adolescents.
Right. We are going to explore the literal architecture of the developing brain, the almost magical mechanics of play therapy, the extreme difficulty of getting a teenager to actually trust you.
And we can't forget the legal side.
Oh, absolutely. The terrifying legal and ethical minefields that therapists navigate every single time they close the office door.
I am thrilled we are digging into this. Because, once you understand the hidden mechanisms of how young minds process trauma and navigate the world, it fundamentally changes how you view every interaction you have with a child.
It really does.
You stop seeing a tantrum as a personal attack, and you start seeing it as a desperate attempt at communication.
Okay, let's unpack this from the ground up. Because before we can even begin to talk about how to treat a young person, we have to understand what is happening inside their head.
Right, the actual neurological hardware.
Yeah. And to do that, we have to look at the cognitive scaffolding. Our sources dive into Jean Piaget's cognitive stages, and I specifically want to talk about this concept of concrete operations.
Oh, that's such a crucial stage.
Because this seems to be the exact reason why asking a kid, how does that make you feel, usually just gets you a blank stare.
It does, and it really comes down to that biological hardware. The concrete operations stage typically spans from about age 7 to age 11.
Okay, so elementary school age.
Exactly. Now, at this age, a child can absolutely think logically. I mean, they understand cause and effect, but their logical thinking is strictly tethered to the physical, tangible world.
Meaning what, exactly?
It means they need to be able to see it, touch it, or directly experience it to process it.
So they are literalists.
Profound literalists. What they lack is the abstract verbal capacity for hypothetical mapping.
Well, let's ground that in a real scenario so we can really picture it. Say I have an 8-year-old who just maliciously broke his sister's favorite toy.
Okay, a classic sibling conflict.
Right. If I sit him down and say, I want you to really imagine how your sister felt when she saw her toy in pieces. Put yourself in her shoes. What is actually happening in his brain?
Well, in an adult brain, that prompt triggers a really complex simulation. You access memories of your own grief, you project them onto another person, you evaluate the hypothetical emotional fallout.
The kid.
In an 8-year-old's brain, you're asking them to run a software program they literally haven't finished downloading yet.
Wow.
Yeah. They might understand that they broke a rule, and they might fear punishment. But generating a purely hypothetical, abstract, emotional landscape based entirely on spoken words.
They just can't do it.
They literally cannot do it. They will just draw a blank. Or, they'll give you whatever rote answer they think will get them out of trouble.
Which totally explains why standard talk therapy is completely useless for that age group. You're demanding that they use a language of abstraction that doesn't even exist for them yet.
Exactly. You have to anchor their thoughts to observable objects. If they can hold it in their hands, they can process the emotion attached to it.
And that neurological reality is the entire foundation for play therapy, right?
It is. It's the whole basis for it, which we will definitely dig into shortly.
But before we get to the sandbox, we have to talk about what happens when that childhood rigidity gives way to adolescence.
Ah, the teenage years.
Yeah, because if childhood is a state of constant literal flux, adolescence is like a Category 5 hurricane. It's this period of profound biological, cognitive, and social ability.
Everything is shifting simultaneously. It is a massive systemic overhaul.
I mean, the brain is physically pruning itself, hormones are flooding the system.
And there's a total structural shift in social dependence. They're pulling away from their parents and desperately trying to integrate into peer groups.
But the emotional driver of this period is what I find most fascinating in the literature. When we think of teenagers, we usually think of anger, rebellion, or maybe angst.
Sure, the classic rebellious teen stereotype.
Right. But the sources point out that the actual core disruptive emotion for early adolescence is shame.
Yeah, shame is the massive driver here.
I want to push back on that a bit, or at least figure out the mechanics of it. Why shame? Why is a 13-year-old fundamentally driven by the fear of being humiliated rather than just being, angry at the world?
It goes back to that shift in social survival we just mentioned. When you are a child, your survival depends entirely on your parents.
Right, they feed you, they house you.
Exactly. As long as mom and dad are okay with you, you're safe.
Yeah.
But in adolescence, the biological imperative shifts to tribal integration.
So the peer group.
Yes, your survival socially, and in an evolutionary sense, literally depends on being accepted by your peers. Therefore, any perceived flaw, any ridicule, any embarrassment feels like an existential threat.
It feels like life or death to them.
It really does. The feeling of being fundamentally flawed or rejected by the tribe is shame. And it is so overwhelming that the adolescent ego will do almost anything to defend against it.
So what we label as acting out is actually an emergency defense mechanism.
Precisely. To survive the agonizing pain of shame, they deploy intense psychological defenses. They use outright denial, like refusing to accept a reality that makes them look foolish.
And projection, right. The sources mention projection.
Yes, projection is fascinating.
Yeah.
That's when they take their own unacceptable feelings of insecurity or inadequacy and aggressively attribute them to someone else.
Like saying, I'm not stupid, my math teacher is an idiot.
Exactly. And they regress. The slamming doors, the refusal to communicate, it is an internal ego-defending mechanism trying to cope with an unbearable sense of exposure.
But we can't just write off all adolescent turmoil as normal growing pains.
No, definitely not.
There's a critical point where normal ability turns into clinical pathology. And a big part of that has to do with how these struggles interact with other vulnerabilities.
Like comorbidities.
Right. For example, if a child has a learning disability or an intellectual disability, the numbers here are just staggering. Kids with an LD or ID have a 25 to 50% rate of comorbid conditions like depression, anxiety, or ADHD.
Up to half of them are fighting a multi-front war.
And if you look at their daily lived experience, you immediately understand why. Imagine being a child with a severe reading disability. Every single day, you are forced into an environment school that demands the exact skill you lack.
It's relentless. You sit in a classroom feeling intellectually inferior. You face the thinly veiled frustration of overworked teachers.
And the mockery or the pity of your peers.
Exactly. That environment acts as a relentless incubator.
So you're saying the depression isn't necessarily a biological inevitability of the learning disability. It's a psychosocial reaction to how the world treats the disability.
Often, yes. It generates internalizing disorders, like severe depression or somatic anxiety.
Like physical stomach aches, headaches.
Right. Or conversely, it breeds externalizing behaviors. If you feel incredibly stupid in class, the easiest way to protect your ego from that shame is to become the class clown or the bully.
You act out aggressively to distract everyone from the fact that you can't read the assignment.
Exactly. It's a deflection tactic.
Let's stay on that concept of acting out, because this brings us to conduct disorder. And specifically, the sources discuss this idea of adolescent onset conduct disturbance.
Right, which is a very specific subtype.
This is the teenager who seemingly overnight starts breaking curfew, experimenting with drugs, lying, shoplifting. Now, if an adolescent is biologically wired to separate from their parents and push boundaries, shouldn't we just view this as a phase?
I hear that a lot from parents.
I can imagine. I hear frustrated parents saying, let's just wait it out, they'll mature. Why intervene clinically?
Because waiting it out assumes that the environment will remain harmless while they experiment, and that simply isn't true.
The stakes are too high.
Exactly. Adolescent onset conduct disturbance is often rooted in normal, exaggerated rebellion. But when these behaviors become frequent, they begin to fundamentally derail the child's developmental trajectory.
Because they're missing out on normal life stuff.
Right. If they are constantly skipping school, they miss critical educational milestones. If they're using substances, they alter their neurochemistry. But more deeply, it represents a catastrophic breakdown in the normative authority structure of the family.
Meaning the parents are no longer the anchor.
Exactly. In a healthy family system, parents must remain the ultimate authority. I don't mean authoritarian dictators, but they have to be the guardrails.
The boundary line.
Yeah. When a teenager's impulses for immediate gratification completely overpower the requirements of socialization, and the parents have lost the ability to enforce boundaries, that child is in free fall.
So you really cannot just wait it out.
You can't, because antisocial behavior is self-reinforcing. The longer they practice it without encountering an immovable boundary, the more ingrained it becomes in their personality structure.
This leads to one of the most illuminating distinctions I've encountered in the deep dive regarding misbehavior. Conduct disorder isn't just a monolith.
Far from it.
It's divided into two distinct categories based on what is actually broken in the child's processing system. We have motivational factors versus capability factors.
And this distinction changes everything about how a therapist or a parent approaches a troubled kid.
Let's look at the motivational impairment first. This is usually tied to the adolescent onset we just discussed, right?
Yes. These teens are proactive, they can be callous, and quite unemotional about their rule breaking.
They know exactly what the speed limit is. They just enjoy driving 90 miles an hour.
That's a great way to put it. They break the rules because they want the reward. The thrill of the theft, the high of the drug, or just the convenience of avoiding their chores.
And what's the clinical marker there?
The key clinical marker here is that they are incredibly under-responsive to negative consequences.
Oh, meaning punishments don't work.
Exactly. You ground them, you take away their phone, you yell at them, it just bounces off. They don't experience that internal physical anxiety about getting in trouble that stops the rest of us from doing bad things.
Because their motivation system is entirely skewed toward immediate reward and blind to long-term risk.
Right. But then you have the capability impaired group, and this usually surfaces much earlier in childhood.
This isn't about a callous disregard for the rules, is it?
Not at all. It is a completely different pathology. Capability impaired kids are reactive, not proactive. They're often highly agitated, volatile, and crucially, they usually feel immense remorse after they explode.
Oh, so they actually feel bad about what they did.
Yes. They want to be good. They understand the rules, but they fundamentally lack the emotional self-regulation and the executive cognitive functioning required to stop themselves in the moment of stress.
I'm trying to visualize the mechanics of this. So it's like they are driving a car and they see the red light and they desperately want to stop, but the brakes are literally disconnected.
That is exactly what is happening, and we can prove it neurologically. When these capability-impaired children face a stressor, say another kid cuts in front of them in line, they suffer from amygdala hyperresponsiveness.
The amygdala, that's the fear center, right?
Right, this Brady's primitive alarm system. It handles fear and aggression. In these kids, it's like a car alarm that goes off because a gentle breeze touched the windshield. The amygdala floods their system with adrenaline and rage.
And what about the brakes? You said they were disconnected.
The brakes are the prefrontal cortex, the area right behind your forehead responsible for logic, forethought, and impulse control.
Okay, so what's happening there?
In capability-impaired individuals, prefrontal cortex functioning is demonstrably weak. In fact, brain imaging of adults with serious histories of capability-based violence shows low volumes of gray matter.
Wait, literally less brain matter.
Literally. Specifically, they have fewer dendrites, which are the branches that connect neurons, in their prefrontal cortices.
That's incredible. So the biological circuitry required to pause, feel conscience, and exercise self-control is physically diminished.
Yes. And this physical deficit can be influenced by genetics, but also by early environmental trauma or exposure to neurotoxins.
Like what kind of neurotoxin?
Like lead paint in older housing or fetal alcohol exposure. The point is, when a kid with capability-based conduct disorder punches a hole in the wall, it is often a fundamental biological deficit in their neurological hardware, not a moral failing.
Okay, so put yourself in the shoes of a therapist for a second. You're sitting across from a young child whose brain is stuck in literal concrete operations. Or you're dealing with a kid whose amygdala is constantly screaming while their prefrontal cortex is offline. You cannot talk your way through that.
No, absolutely not.
You cannot use Socratic questioning on a traumatized 6-year-old. So how do you reach them?
This is where we get to the really good stuff.
Yes. This brings us to one of the most fascinating and honestly beautiful mechanisms in all of psychology. If they cannot speak your language, you have to speak theirs. And the universal language of childhood is play.
Play is the foundational mechanism of pediatric therapy. It is not frivolous. It is not just a way to kill time while the adults talk.
Though it can definitely look like that to an outsider.
It can, but it's not. Play is the primary mode of communication, learning, and emotional processing for the developing brain.
It is so deeply ingrained in human development that it is actually protected by international law.
Yes, the UN Convention.
Right. Article 31.1 of the United Nations Convention on the Rights of the Child formally recognizes and protects a child's right to engage in play. It is treated as a fundamental human right alongside the right to food, shelter, and freedom from violence.
Because without play, optimal cognitive and emotional development is biologically impossible. A child who is deprived of play will suffer severe developmental deficits.
So for a therapist, the playroom isn't just a comfortable setting. The toys are the child's vocabulary. The physical act of playing becomes the syntax of their trauma.
That's a beautiful way to phrase it.
Let's break down exactly how this works because the sources show it isn't just random. A researcher named Charles Schaefer categorized the specific therapeutic powers of play.
Yes, the curative factors.
Exactly. He identified distinct curative factors that occur when a child engages with toys. Let's start with one of the heaviest ones, ebreaction. What is the mechanism here?
Ebreaction is essentially the process of reliving and mentally digesting a horrific, overwhelming experience.
Okay, so processing trauma.
Right. When a trauma occurs, say a child survives a violent car crash, the emotional payload is too massive for their brain to process all at once. It gets stuck.
So how does play help?
In play therapy, you will see a child take two toy cars and aggressively, repetitively smash them together, over and over again.
Which, to an untrained observer, just looks like a kid being destructive, or maybe even hyperactive.
Right, but what is actually happening is profound. By reenacting the trauma in a safe, controlled space, the child is taking an event where they were entirely helpless and terrified, and they are becoming the active director of the event.
So they are in charge now.
Yes, they control the speed of the cars, they control the noise.
Yeah.
Through this repetitive play, they are slowly metabolizing the overwhelming emotions attached to the memory.
They are draining the venom from the memory by gaining a sense of mastery over it.
Exactly. Then there is stress inoculation. If abreaction is about digesting the past, stress inoculation seems to be about fortifying against the future.
Yes, because children have very little control over their lives, which means upcoming events can cause crippling anticipatory anxiety.
The unknown is terrifying for them. Things like a surgery, starting a new school, moving to a new foster home.
So play therapy allows them to run a simulation.
Precisely. If a child needs to have their tonsils out, the therapist might provide a toy medical kit and a doll. The child gets to be the doctor.
So they use the toy stethoscope, they give the doll a pretend shot, they pin a bandage on the doll.
They're mapping the territory before they have to walk through it. It takes the strange, chaotic, and terrifying unknown and makes it familiar, predictable, and manageable.
The anxiety shrinks because the scenario has already been conquered in the playroom.
Exactly.
I want to dig into a third curative factor, counterconditioning. I am fascinated by this because it relies on a very simple, almost mechanical biological premise.
It really does. The premise is biological exclusivity.
Okay, explain that.
The human nervous system is incredibly complex, but it has certain hard limits. Two mutually exclusive internal emotional states cannot exist in the body at the exact same time.
Like you can't be hot and cold at the same time.
Right. You cannot be profoundly physically relaxed and profoundly physically panicked simultaneously. You cannot experience deep, spontaneous joy and crushing anxiety at the exact same moment.
Because the body just can't do it.
Exactly. The physiological markers, heart rate, respiration, neurotransmitter release, are completely opposed.
I'm trying to figure out how this applies in the playroom. So if a kid has a crippling phobia of the dark, how does play fix that? Aren't you just distracting them if you make them play a game?
It's not a distraction, it's a physiological override.
Wow, okay.
If a child is terrified of the dark, a therapist might introduce a game of hide and seek or a flashlight tag game in a darkened room.
And the game naturally induces positive effect.
Yes. The giggling, the thrill of hiding, the joy of being found. That spontaneous joy triggers a physiological response that physically crowds out the anxiety. The positive affect of the play counter conditions the negative affect of the fear.
Over time, the brain rewires its association with the dark from terror to fun.
Exactly.
It sounds to me like play therapy is a sort of emotional Trojan horse.
Oh, that's a perfect analogy.
Because the child walks in and thinks, great, I'm just building a sandcastle, or I'm making this T-Rex fight a Triceratops.
Yeah, they think they're just playing.
But hidden inside that entirely natural activity is a highly effective mechanism for confronting deep-seated trauma, all without ever triggering their conscious verbal defense mechanisms.
That is exactly it. The toys provide symbolic distance.
Symbolic distance. I like that.
If I sit across from a 9-year-old and ask, why are you so angry at your father? I am demanding a level of insight they don't have, and I'm triggering their defenses.
They might feel intense loyalty or fear or guilt.
And they will shut down. But if I observe them playing and I say, wow, that big bear is really yelling at the little bear looks scared, the child can safely project all of their internal terror and anger onto the plastic bears.
Because it's not about them, it's about the bears.
To their conscious mind, yes, it is entirely safe. But the neurological and emotional processing taking place is identical to a breakthrough in adult talk therapy.
Now, play therapy is an umbrella term. It's not just a free-for-all room full of toys. There are highly structured, distinct modalities depending on the theoretical approach.
Yes, there are many different schools of thought.
Let's walk through a few of the major ones outlined in the sources. It seems like the bedrock modality is child-centered play therapy, or CCPT, and this is heavily based on Virginia Axeline's 8 principles.
CCPT is deeply rooted in humanistic Rogerian psychology. The core belief is that the child inherently possesses the capacity for self-healing, provided they are in the right environment.
So the therapist doesn't tell them what to do.
Correct. In CCPT, the therapist is not a director. You do not interrogate the child. You do not suggest games. You do not guide the narrative.
So what does the therapist actually do? What if the kid just sits there?
The therapist practices radical patience and profound acceptance. Your job is to establish a warm, highly permissive relationship. The therapist acts as a reflective mirror.
Give me an example of that.
If the child is aggressively burying a doll in the sand, the therapist doesn't ask, why are you doing that?
Because that would be interrogating.
Right. The therapist might simply observe and reflect the emotion. You are burying that doll very deeply. You seem determined to keep it under the sand.
You accept the child exactly as they are in that moment.
Yes. The child leads entirely, and through that unconditional positive regard, they slowly gain the courage to process their own inner turmoil.
But what happens when a child is so traumatized or cognitively so young-like, still deep in that pre-operational stage, that they literally lack the ego strength to initiate the play?
That is a very real challenge.
Because if they can't even pick up the toys because the trauma is too heavy, CCPC might not work. That's where release play therapy comes in, right? Because this sounds completely different. It sounds almost aggressively active on the therapist's part.
Release play therapy, or RPT, is a highly directive intervention for precisely that scenario. If a child has endured a massive acute trauma, say, witnessing domestic violence, but they're too frozen to play it out, the therapist takes the wheel.
Meaning the therapist sets it up.
Yes. The therapist will intentionally set up the scene using specific toys, and then the therapist might actually do the acting.
Wait, the therapist plays with the toys?
Yes. The therapist might make the dolls shout at each other or pretend to cry on behalf of the toys.
It sounds bizarre to an adult mind, like a grown professional playing make-believe in front of a frozen child.
It does sound strange, but for a traumatized young child, it is incredibly powerful. They watch the therapist safely express the intense, terrifying emotions that are trapped inside them.
And because the therapist is doing it, it proves the room is safe.
Exactly. Because the therapist is holding the emotional weight and demonstrating that the room is still safe, even when anger or sadness is expressed, the child can vicariously assimilate the trauma.
That is fascinating. Moving to a more symbolic realm, the texts also cover Jungian analytical play therapy. This brings in Carl Jung's concepts of the collective unconscious, archetypes, and the drive toward individuation.
Individuation is the Jungian goal of becoming a whole, fully integrated person. Jungian play therapists focus heavily on creating a vase.
A vase, what is that?
It's a term borrowed from alchemy. It means a secure, contained vessel or environment where transformation can occur. And the hallmark of Jungian play is sand play.
I've seen pictures of this. It's not just a regular sandbox, is it?
No, it's highly specific. The child is given a shallow tray with a blue bottom, which represents water, partially filled with sand. And surrounding them are shelves containing literally hundreds of miniature figures.
Like what kind of figures?
Soldiers, monsters, religious icons, fences, trees, animals, everything. The child builds a three-dimensional world in the sand.
And what's the theory behind that?
Jungians believe that the psyche naturally produces symbols to heal itself. The child's unconscious mind directs the creation in the sand tray, producing archetypal scenes that facilitate deep internal healing.
And the therapist just watches.
Often, yes. The therapist will just witness this process, taking photographs over weeks without ever needing to verbally interpret the symbolism to the child. The act of creation is the healing.
Then there is narrative play therapy, which often utilizes something called the EPR model. That stands for embodiment, projection, and role play. This feels like it tracks with the child's natural developmental sequence.
It does perfectly. It moves from the physical to the abstract. Embodiment is the first stage, purely sensory exploration.
Like finger painting.
Exactly. This is the child furiously mashing clay or splashing water or finger painting. They're connecting with their physical body and regulating their sensory system.
And the next stage is projection.
Right. Projection is what we've discussed, using puppets or dolls to tell a story outside of themselves. And the final stage is role play.
Where they actually become the character.
Yes. They drop the puppet and physically take on the character themselves. They act out the narrative. This structured progression helps a child take fragmented, chaotic, traumatic memories and organize them into a cohesive beginning, middle, end story.
And finally, there is solution-focused play therapy, which struck me as incredibly pragmatic compared to the others.
It is definitely the most forward-looking modality. Traditional therapy often digs endlessly into the past, searching for the root of the trauma.
Right, asking what happened to you.
Exactly. Solution-focused therapy assumes the trauma is there, but asks, what does life look like when this problem is solved?
So how do you play that out?
The therapist uses play, maybe drawing a picture or using puppets to help the child vividly imagine a successful future. Like, show me what the brave puppet does when it's time to go to sleep.
It builds a tangible, rehearsed roadmap for success rather than just wallowing in the past injury.
Exactly. It's very empowering.
Across all these modalities, there are specific techniques that are just brilliant in their simplicity. I want to highlight the Color Your Life thermometer. How does this help a child?
It's a wonderful psychoeducational tool. If you ask a 7-year-old to quantify their depression, they can't do it.
They don't have the vocabulary.
Right. But if you give them a drawing of a blank thermometer and a box of crayons, you can establish a code. You agree that red means angry, blue means sad, yellow means happy, and black means scared.
And then they color it in.
Exactly. You ask them to color in the thermometer to show how much of each feeling they've had inside them this week. Maybe it's half blue, a quarter red, and a little bit of yellow.
It gives the child an indirect, visual way of quantifying complex, mixed emotions.
Yes, it makes the abstract visible.
And then there are aggressive energy activities like the splat game.
Oh, the splat game is great.
Yeah.
Kids with severe anger or capability-impaired conduct issues have a massive amount of physical aggressive energy. You cannot just tell them to calm down.
Right, that energy has to go somewhere.
The splat game involves allowing a child to throw wet paper towels as hard as they can against a specific wall, or popping balloons, or smashing a specific block of clay.
It provides a safe, contained vessel for catharsis.
Exactly. And the psychological lesson is profound. Your aggressive energy is not inherently evil, but you must learn to express it in a safe, controlled manner in an appropriate setting.
It is incredible how these tools bypass the cognitive limitations of childhood. But, children grow up.
They do?
Eventually, they abandon the sandbox, they outgrow the puppets, we enter the messy, volatile middle ground of adolescence. Teenagers are desperately trying to individuate from their parents, but they lack the economic and emotional independence of actual adulthood.
It's a really tough transition period.
So, when the toys go away, how does the therapeutic approach shift?
It has to shift dramatically because the adolescent's perception of the therapist is completely different from a child's. A young child generally views adults as helpers or caretakers. But as we discussed earlier, an adolescent is biologically driven to separate from the family and align with peers. So when a 15-year-old is forced into a therapist's office by their mother, they do not see a helper.
They see an authority figure.
They see another adult, intrinsically aligned with their parents, whose entire job is to analyze them, judge them, and control them. They view counselors with intense suspicion and hostility.
Which raises a massive clinical challenge. If you are a therapist, how do you build an alliance with a teenager sitting on your couch, arms crossed, rolling their eyes, utterly convinced that you are just a highly paid narc for their parents?
You have to fundamentally surrender your authority.
Wait, surrender authority.
Yes. The literature refers to this as building an authentic person-to-person relationship. You cannot hide behind the authority of your degree or your title or your age.
Because teenagers see right through that.
Teenagers have a flawless radar for condescension and inauthenticity. The therapist must actively, continuously respect the teen's developmental need for autonomy and power.
So you don't dictate solutions.
No, you collaborate. You treat them as a consultant on their own life. By sharing power and validating their desperate need to be seen as mature, you slowly lower their defenses.
This intense need for autonomy completely illuminates a statistic that initially surprised me in the research: the massive global success of telephone counseling for teenagers.
Oh, it's hugely successful.
Services like Childline in the UK or Kids Helpline in Australia receive millions of calls. Why is a phone call so much more effective for a certain demographic than an office visit?
If you view it through the lens of adolescent development, it makes perfect sense. Telephone counseling offers two critical things that an in-person office visit strips away: total anonymity and absolute control.
Right, think about the dynamics. The teenager decides exactly when to call.
They decide exactly how much truth to reveal without the pressure of eye contact. And crucially, they hold the physical power to simply hang up the phone at any second.
That dynamic perfectly aligns with their developmental need for autonomy.
It really does.
Yeah.
They're seeking help, but they're doing it entirely on their own terms, safely behind a shield of distance.
But for teens who are in formal long-term therapy, especially those dealing with the conduct disorders we unpacked earlier, the interventions are much more structured. And you mentioned that the approach must match the etiology, the root cause of the behavior.
Exactly.
So let's break that down. If a therapist is treating a capability-impaired teen, the reactive kid whose brakes don't work, who gets furious and then feels guilty, what is the therapeutic approach?
For the capability-impaired adolescent, the focus is heavily on cognitive behavioral therapy and collaborative problem solving.
Because they lack executive functioning.
Right, so the therapy involves explicitly teaching them the cognitive skills they're missing. You work on emotional vocabulary, you role-play conflict resolution, you practice the physical act of pausing when the amygdala fires.
You are essentially acting as a surrogate prefrontal cortex until theirs catches up.
That's a great way to put it. And the parents are heavily involved, but in a very supportive coaching capacity.
But what if you have the other type? The motivational impaired teen. The proactive, callous rule breaker who just wants the reward and doesn't care about the consequences. I imagine CBT fails miserably there.
CBT often fails completely with this group because you can't teach empathy or problem solving to a kid who simply doesn't care about the problem.
If you ask them, how do you think your victim felt, they will just shrug.
Exactly. For the motivational impaired teen, the intervention requires behavioral systemic parent training. In fact, a lot of the therapy doesn't involve the teen at all. It involves training the parents.
Training the parents to do what?
To completely change the mathematical equation of the teenager's behavior. These teens operate on a crude cost-benefit analysis. The parents must be trained to implement strict, inescapable reinforcement contingencies.
Like the 1-2-3 method.
Yes, for immediate compliance.
Yes.
Or response cost, where every single infraction immediately automatically costs them a highly valued privilege.
No arguing, no second chances.
No emotional pleading. It is about constructing an environment where breaking the rules is so consistently, reliably unprofitable that the teen's own selfish motivation forces them to comply.
There is a visual metaphor used in the literature to describe the parents' role in this process, and I found it profoundly moving. It says that parents of severely oppositional teens must learn to be like rocky cliffs by the ocean.
It is a vital, stabilizing metaphor for exhausted parents. Think about the dynamics of living with a highly oppositional, explosive teenager.
It's exhausting.
That child is going to unleash sound and fury. They're going to crash against the rules and the boundaries like violent, chaotic waves during a storm. They will yell, they will hurl insults, they will try to erode the family structure.
So what does the parent do?
The parent's job is not to become a louder storm. The parent's job is to be the rocky cliff. You absorb the impact of the wave. You do not move a single inch. You do not retreat. And crucially, you do not let the storm damage you.
You don't retaliate.
Exactly. The natural instinct when a teenager screams, "I hate you," is to scream back or to punish out of anger. But a rocky cliff doesn't yell at the ocean.
The parent must demonstrate unconditional love and unwavering normative authority in the face of profound mistreatment.
By remaining calm, enforcing the consequence without emotional vengeance, the parent provides the immovable structure that the teenager secretly, desperately needs, even as they fight it with everything they have.
Listening to this, it becomes incredibly clear that being a child or adolescent counselor is not just sitting in a room nodding sympathetically.
Far from it.
The therapist is actively navigating the teenager's fierce desire for absolute privacy, the parent's desperate, sometimes manipulative desire for control, and the clinical, legal necessity to keep everyone physically safe. It sounds less like healthcare and more like navigating a legal and ethical powder keg.
It is a daily tightrope walk over a minefield. The burden of responsibility on a youth counselor is immense, far exceeding that of an adult therapist.
Because a child is legally and practically embedded in a web of competing rights, family systems, and legal duties.
Exactly.
To structure this chaos, the ethical guidelines lay out a framework known as the 5 C's of ethical challenges. Let's establish what these categories are before we dive into how terrifying they look in the real world.
The 5 C's are competence, consent, confidentiality, competing interests, and child maltreatment.
Okay, so almost every ethical or legal crisis a pediatric therapist faces will fall into one or a collision of several of these buckets.
Right.
To really understand how catastrophic it can be when these collide, let's dissect the case study of Emily from the clinical text. I want to build this scenario piece by piece because every detail matters here for you listening.
This case is a perfect storm.
Okay, here we go. Emily is 14 years old. She lives in a rural, isolated town. Her parents are going through a remarkably nasty, acrimonious divorce.
Which is already a high-risk situation.
Right. Emily is caught in the crossfire and starts refusing to go to school. Her mother decides she needs therapy, but the mother refuses to use the local specialized child psychologist, perhaps due to small-town politics or wait times.
And Emily refuses to see the school counselor.
Right, exactly. Emily flatly refuses to see the male counselor at her high school. So, in desperation, the mother takes Emily to a local counselor in private practice. Here is the first massive complication. This counselor primarily treats adults. She has a basic counseling qualification, but her entire specialized training in youth therapy consists of a single one-day continuing education seminar.
We need to pause right there. Before Emily even opens her mouth, we have a massive violation of the first C competence.
Let's unpack why. A therapist is a therapist, right? If she can help a 40-year-old with depression, why can't she help a 14-year-old?
Because treating a child is never, ever just individual therapy. It is what the field calls a forced multiple relationship.
What does that mean?
When you accept a child as a client, you are implicitly accepting their parents, their school environment, and their legal guardians into the therapeutic dynamic. It requires deep, specialized training in family systems, developmental psychology, and pediatric law.
And a one-day seminar doesn't cut it.
A one-day seminar does not equip a practitioner to navigate the psychological and legal complexities of a 14-year-old caught in a toxic divorce. By accepting this case, the rural counselor is working dangerously beyond her scope of practice. She is legally vulnerable and clinically ineffective from day one.
And it immediately gets worse. Before the session even starts, the mother pulls the counselor aside. She explicitly forbids the counselor from contacting Emily's father.
Oh, boy.
The mother wants exclusive control over the medical information to use as a weapon in the divorce proceedings. Furthermore, the mother actively asks the counselor to write a formal letter to her divorce lawyer, stating that the father is an angry man who is detrimental to Emily's mental health in order to deny him custody.
Which brings us crashing into the fourth C, competing interests. And this is a trap that well-meaning, undertrained therapists fall into constantly.
Let me play devil's advocate here. If the counselor meets with Emily, and Emily says her dad is mean and yells a lot, why shouldn't the counselor write the letter? Isn't she advocating for her client?
Absolutely not. First, it destroys the therapeutic alliance. The counselor's only job is to provide a safe, neutral healing space for Emily. The moment the counselor writes a letter to a divorce court, she transforms Emily's private sanctuary into a legal weapon.
She becomes an agent of the mother.
Exactly. But legally, it is even more dangerous. The ethical guideline is ironclad. A treating therapist must never step outside their clinical role to provide expert custody evaluations or legal recommendations.
Because they aren't forensic psychologists.
Exactly. To make a legal recommendation about custody, you need specialized forensic training. You must formally interview both parents, observe their interactions, and you must be hired explicitly for that purpose by the court, not by one angry parent.
So if this counselor writes that letter based only on the mother's demands and Emily's venting, she's practicing way outside her scope.
She is practically inviting a massive malpractice lawsuit, a formal ethics board complaint from the father, and the potential loss of her license.
Okay, so the counselor manages to get into the room alone with Emily. And despite the lack of training, the counselor establishes a rapport. Emily feels safe.
Which is good clinically, but dangerous legally here.
Right, because she feels safe, she drops a bombshell. Emily reveals that she is regularly smoking marijuana with her 15-year-old boyfriend, who is a heavy user.
Okay, so substance abuse.
She also tells the counselor she is strongly considering becoming sexually active with him. Then she looks at the counselor and begs her not to tell her mother, promising she'll stop doing drugs if the counselor keeps the secret.
Now we have a total collision between the second and third C's, consent and confidentiality. And this is where the law becomes incredibly fluid, geographically inconsistent, and deeply frustrating for practitioners.
Because Emily is 14. Does a 14-year-old have a legal right to medical privacy from her own parents? Can she veto her mother's access to her clinical records?
The answer is entirely dependent on where they live, based on the legal doctrine of the mature minor. Is a 14-year-old cognitively and emotionally competent to give informed consent and hold privilege over her own medical records?
And the law varies on that.
Wildly. If you look globally, and even state by state, the philosophies diverge wildly. Progressive jurisdictions tend to lean heavily toward granting minors privacy rights, especially regarding substance abuse, sexual health, and mental health.
That's their logic.
Their argument is pragmatic. If you force a therapist to report a teenager's drug use to their parents, teenagers will simply lie, or they will refuse to seek treatment at all. They prioritize clinical engagement over parental control.
And conservative jurisdictions.
They heavily favor parental rights. They argue that parents are legally and financially responsible for the child and therefore must have absolute, unfettered access to all medical records to make informed decisions for their minor child.
So this underqualified counselor is sitting there with a stoned teenager, trying to remember what her specific state law says about mature minors, while the angry mother is in the waiting room demanding updates. What is the actual ethical way out of this trap?
The only way out of the trap is to never walk into it. The ethical failure happened before the disclosure.
Oh, by taking the case.
Best practice dictates that you conduct comprehensive pre-treatment family meetings. Before therapy ever begins, you sit down with the parent and the teenager together.
Just set the ground rules.
You establish a clear, written, signed agreement about the exact boundaries of confidentiality. You agree on exactly what types of risk like suicidal ideation or hard drug use will trigger a mandatory break in confidentiality and what topics will remain strictly between the therapist and the team.
You build the container before you pour the water in?
Exactly. This counselor skipped that step, and now she is trapped between alienating her client or deceiving the parent.
But Emily isn't done. A week later, Emily arrives for her session in a state of extreme distress. She breaks down and reveals the darkest secret of all. She has been raped by her 25-year-old neighbor.
And with that sentence, all ambiguity vanishes. We have hit the fifth C, child maltreatment.
Let's be explicitly clear about the therapist's duty here for anyone tuning in. Emily might beg the counselor not to tell anyone, fearing the neighbor, fearing the shame, fearing her parents' reaction. Does the counselor have any discretion?
In almost every jurisdiction in the United States and Australia, the answer is an absolute, unequivocal no. The rape of a minor by an adult triggers strict mandatory reporting laws.
No exceptions.
The counselor has a supreme, non-negotiable legal duty of care to report this abuse to law enforcement and child protective services immediately, usually within 24 to 48 hours.
It supersedes everything else.
It supersedes confidentiality, it supersedes the therapeutic alliance, and it supersedes Emily's wishes. If the counselor fails to report it, she faces criminal prosecution and the revocation of her license.
But the clinical literature notes some really profound global differences regarding this exact scenario, which blew my mind when I read it. Mandatory reporting feels like an obvious moral absolute, but not every country agrees.
It is a fascinating ethical debate. If we connect this to the broader global picture, countries like the United Kingdom and New Zealand have historically strongly resisted blanket mandatory reporting laws for professionals.
Why? How could you argue against reporting the rape of a child?
They aren't arguing in favor of abuse. They are arguing about the systemic behavioral economics of at-risk youth.
Okay, unpack that.
Their philosophy, often backed by public health data, is that mandatory reporting laws can have a chilling effect on the most vulnerable populations. Imagine a pregnant teen or a teen fleeing abuse or a teen addicted to heroin.
Right.
If they know that walking into a clinic guarantees that the doctor or counselor must involve the police or government agencies, those teenagers will simply vanish into the shadows.
They just won't go to the clinic.
They will stop utilizing essential, life-saving services like family planning, addiction counseling, or mental health support.
So these countries prioritize keeping the teenager engaged in the healthcare system.
Yes, believing that maintaining a trusting therapeutic relationship is the best long-term way to guide the teen to safety, rather than forcing a police intervention that might drive them underground.
It is a profound philosophical difference, prioritizing immediate legal intervention versus long-term clinical engagement.
Exactly. But returning to our case study, in Emily's location, the law is clear, and the report must be made.
Listening to this entire scenario, the sheer weight of the burden on the therapist is suffocating. You are managing constant legal threats, you are absorbing the trauma of violated children, you are fending off manipulative parents trying to use you in divorce court.
It's exhausting just talking about it.
It requires an almost superhuman level of emotional regulation. How do therapists not just crack under the pressure or start projecting their own unresolved issues into the therapy room?
That is the silent, pervasive danger of the profession. Transference and countertransference. It requires immense, continuous clinical supervision to avoid.
Let's define those clearly, because they happen in everyday life, not just in therapy.
Transference is when the client unconsciously projects their feelings about a significant figure in their life onto the therapist.
Like an angry teenager treating the therapist with the same venom she feels toward her controlling father, testing to see if the therapist will punish her the way her father does.
Spot on. But countertransference is the real danger for the practitioner. That is when the therapist projects their own unresolved history, their own emotional baggage onto the child.
Give me a real-world example of how that ruins therapy.
Imagine a therapist who, as a teenager, had incredibly strict, emotionally withholding parents. She was a rebel. She felt misunderstood. Now, she is treating a 15-year-old girl who is breaking curfew and fighting with her strict parents.
I see where this is going.
It is incredibly easy for that therapist to unconsciously over-identify with the teenager. She sees her own teenage self sitting on the couch.
So she takes the teenager's side.
Exactly. She falls into what we call the anti-parent position. She subtly colludes with the teenager. She validates the rebellion. She views the parents as the enemy. And it feels wonderful in the moment.
It feels great to be the cool adult who finally understands the misunderstood kid.
But it's toxic.
It is clinically destructive.
By taking sides, the therapist has abandoned her neutrality. She is no longer treating the family system. She is fulfilling her own unmet teenage needs.
Maintaining professional, rigid boundaries is a matter of clinical survival.
The therapist must constantly, actively remind themselves, I am not this child's surrogate parent. I am not their teacher. I'm certainly not their friend.
You're a professional.
I am a highly trained professional, providing an exclusive, temporary, legally bounded sanctuary to help this child process their pain. Maintaining that distance while still projecting warmth is the true art of child psychology.
We have covered an immense amount of ground today, and honestly, it reshapes the entire landscape of how we view youth. We started by looking at the literal, physical neurobiology of the developing brain. We learned that a child's rigidity isn't stubbornness, it's concrete operations.
We learned that violent tantrums and profound rebellion are often rooted in the literal architecture of a child's gray matter, a hyper-responsive amygdala clashing with an underdeveloped prefrontal cortex.
We explored how play therapy miraculously bypasses those cognitive limitations. By using toys as a language, the playroom becomes a safe container for abreaction, allowing a child to digest trauma, or utilizing counter-conditioning to let spontaneous joy crowd out crippling fear.
We navigated the incredibly delicate negotiations required to counsel suspicious defensive adolescents.
We discussed the necessity of yielding authority, the logic behind telephone counseling, and the exhausting, vital metaphor of parents standing as rocky cliffs against the crashing waves of their teen's fury.
And finally, we walked through the terrifying ethical tightropes the therapist must walk when managing consent, custody disputes, and the heavy mandate of abuse reporting.
The ultimate takeaway here is a profound shift in perspective. Whether you are a parent raising a child, a teacher managing a classroom, an uncle, or just someone observing a meltdown in a grocery store, understanding these underlying mechanisms changes everything.
You realize that young people almost always communicate their deepest pain, their shame, and their biological deficits through their behavior and their play.
They aren't trying to give you a hard time, they are having a hard time.
And recognizing that distinction is the very first step toward actually helping them heal. But as we look to the horizon of how childhood is evolving, this raises a massive, vital question, something I want you to deeply ponder after this deep dive ends.
What's that?
We have talked extensively about how physical play, the sandbox, the galls, the physical act of painting or throwing clay, is the fundamental, natural language of a child's developing brain. And we've seen how telephone helplines offer the safe distance that adolescents crave.
Right. But we are currently witnessing a rapid, total, global shift toward digital screen-based childhoods.
Oh, wow, yeah. iPads, video games.
Exactly. If a child's primary daily mode of play becomes entirely digital, if they're socializing on TikTok, building worlds in Roblox, expressing themselves solely through screens, how will that change the way future generations process trauma?
That is a staggering thought. Can you achieve a reaction by mashing buttons on a controller?
If the physical sandbox of traditional play therapy eventually loses its resonance for a child raised entirely in the digital ether, will that physical playroom become obsolete?
Or, conversely, will that physical, tactile, messy playroom become the absolute last, desperately needed grounded sanctuary they have left in an increasingly virtual, disembodied world? That's an incredibly profound thought to leave on. The nature of childhood is changing, and the tools of healing will have to race to keep up. As always, thank you for guiding us through these incredibly muddy diagnostic waters with such clarity.
It was my pleasure. And for you listening, keep looking beneath the surface, keep questioning the obvious, and keep seeking out the why behind the what. Until next time, thanks for joining us on the Deep Dive.